Salam to come in, but I always know that once he gets a coffee, he never come back. And I hope he will come back. You can get him? I don't think nobody can get him. He will fly from you. Anyhow, let's start because a little bit late. The challenge sometimes could be in the diagnosis. Sometimes you see the patient, you have a challenge in the diagnosis, but once you diagnose the patient, the challenge is how to treat this patient. Is it to observe? Is it to treat? Is it to do something, to inject? And the challenge could be in the history. Sometimes the patients, we always know, deny that he had this or trauma or injection or whatever. He denies because he wants to see your skills. Sometimes I see patients in Egypt and I said, what are you complaining from? He said, you will find out. You are the doctor. You are the professional. So they never give you any history. And once you ask about the history, they deny everything at the beginning. But once you reach the diagnosis, they start to tell you, yes, I do have this, I did that. This is a way of challenge. So I give every case like a title, so I will attract you. Never stop, follow up, whatever the age of the patient and whatever, of course, your age as a doctor. This is the case of 80 years old male. He had recent diminution of vision, 636, 624. He had nuclear cataract. Fundus, he had bilateral vitelliform lesion, and I will show you the lesion in a minute. It is not a trick, it is not a mystery. It's a case I met, and I will tell you what happened and what happened to the case later on. I do fluorescein and OCT at baseline, but I couldn't do fluorescein angiography. He's old, he had some renal problems, but anyhow, I did OCT and OCTA. And I'm showing you the picture. This is the picture of the OCT. And it shows vitelliform material with a sensory-like detachment. We all know that this is the elevation of the retina we hear. And there is hyperreflective material here, and there is a vitelliform lesion in the center of the macula. So this is the OCT angio, because sometimes we expect that this patient would get a CNV, but he's 80 years old. OCT angio is free. Diminution of vision because of the cataract and because of the center involved. And this is OCTA, which excluded the CNV, and this is also the left eye. This patient asked me one question, and I'll ask it to the panel. Can I develop CNV? Of course, I said, you might have. But when? I couldn't answer that question. And I said, you have to follow up with me. This is the questions for you. How long I would bring the patient in for follow-up? What is his visual prognosis? He asked me, would I lose my vision? You know, I'm living alone. I depend on myself. And what is the fate of this lesion if I left it without any treatment? Because I told him there is no treatment for this. You have to be followed up. Shall we start by Dr. Gharabli? And I need a quick, because we have 7 cases if you can finish that. How long I should bring the patient in? What's the visual prognosis in this case?
Are you waiting for answers from my side?
You're everybody. I mean,
anyway.
You are in Emirates. Some people are from Morocco. Some people are from India. I was from
fine.
Egypt.
What I'm saying is there is no definitely any consensus or any golden rules here. Just I follow up. I'll just make it every 3 months. Visual prognosis, usually for the vitelliform, it can stay stable for years without having any problem.
Or it could.
But it doesn't mean that we'll not follow up, because, as you say, the CNV can develop at any time. Fate of the lesion, it can stay like this or can end up with CNV, and with the CNV there, just you'll treat. But as long as there is no CNV, you will just get on.
Anybody wants to add anything quickly?
Counseling of the patient would be very important. You need to tell him that if the CNV develops, he need to have something like portable.
We are consisting on CNV, but if there is any other fate than CNV, Dr. Rao, any other fate?
I think one thing in vitelliform lesions is they can actually.
It's not me anyhow.
Okay. Vitelliform lesions can actually collapse, and when they have a collapse, they have atrophy of the RP, and they can lose vision because of that. So it's not only the neovascular path, but also the atrophic path.
This is a quick answer. Follow up. It might turn into CNV. It might turn into atrophy.
Atrophy. Yeah.
Dr. Zidi, would you like to add anything?
I don't have experience to the treatment which some colleague proposed, like subclinical laser to treat it, but in these cases it's not.
As you said, there is no experience, there is no literature, so we will follow up. Anything in India will tell the patient.
So one thing is his age is 80 years of age, and if you see that deposits, they're like not completely homogeneous. So we also have to keep in mind of secondaries sometimes.
Say that again.
The secondaries, from the metastasis also we need to keep in mind.
Metastasis. No, systemically he was free. Because if he had metastasis at this age, he's 80. I don't think he will continue. We will not follow him up. Metastasis will finish the job, I think. So anyhow, I told the patient, as you said, it might turn into atrophic, it might turn into CNV. But he told me, he's 80. So am I going to turn atrophic, I will lose the vision? I said, no, central vision, but the paracentral area, you will keep this. So I didn't expect his lifespan. I mean, that was 10 years ago. But this is 6 years later. The guy came back suddenly with sudden drop of vision, and he said, I lost the vision. It means that he was seeing well. I mean, if he complained of one eye like this, I gave him an Amsler grade, by the way. Thank you, Dr. Ahmed, for coming with the coffee. Thank you so much. Thank you. Because I didn't expect you to come back. I told everybody that you went for coffee, and it takes 1 hour in the United Arab Emirates to get coffee, so you will catch us at the end. But anyhow, I'm glad that you're here. Thank you so much. So it's 6 years. So you will never expect that 6 years later, in this age, that he developed a CNV. And he developed a CNV. So this is for the audience. You should never tell the patient that the age is a contraindication for developing CNV. And sometimes you can develop CNV in the long term, and you'll never know what will happen. But this is a CNV after 6 years. And at this stage, there is no doubt about it that we will start injecting this patient. And we all know that sometimes CNV regress quickly because it's like AMD with a vitelliform. Look at the other eye. On the other direction, you can develop atrophy, but he had more or less stable vision in the left eye. So again, it's two-way, developing CNV or atrophic, but don't tell the patient after 3 or 4 years of follow-up, you should be safe, you shouldn't follow up anymore, because it can happen even in 10 years to develop a CNV. You will never know how long it takes to have a CNV. I'm sorry? It's atrophic. In the left eye, it's collapsed. This is the left eye. It collapsed. I don't think in the young age we can see sometimes in the adult form in 40s or 50s they increase the deposits of the lipofuscin, but here it will collapse because it's the natural course of this. It will induce atrophy in the retinal pigment epithelium. So probably I was expecting that he will collapse and his life will collapse, but he did not collapse. The guy is living after 6 years with a CNV, starting injection at the age of 86. I never expected that, because after 3 years, telling you the truth, after 3 years of follow-up, I told him, you can come every year. If anything happens, you have the Amsler grid. So he came 3 years later. This is what astonished me. Never stop the follow-up, whatever the age of the patient. So this is a very important point to notice, and put in mind, whatever the age of the patient, whatever he had, he might have complication later on. So don't lose the patient and don't feed up of following the patient. And this is the message.
Two points. One is, if you have multifocal vitelliform lesions, especially in elderly patients.
In young patients?
In young patients or elderly patients, not young patients.
Okay.
And you do a EOG for them, and it turns out to be normal. Please rule out paraneoplastic syndrome, because paraneoplastic.
Yes, I do agree.
Yeah.
They get like pseudo-vitelliform. They have, now we have everything, it's turned into vitelliform, like pachyvitelliform. Everything is going into vitelliform. The RPE can, make lipofuscin, and they give you different things. So this is another good point. Sometimes the multiple, you have to have a systemic workup. This is the title of the second one, because will take a long time to discuss with you, because I have 10 years follow-up for this guy. So CNV management is not always easy. This is a clash now. We have OCT and OCT angio. And a lot of people say, OCT is quite good enough to treat the patient. Don't do OCT angio for most of the patients. As long as I have an OCT angio, I do for that for myself, because I need to learn what is going on for this patient. And this is what I said, clash between two authorities. 77 years old male presented with left recent diminution of vision after phaco. Best corrected visual act 618. OCT shows flat irregular RP detachment. I will show it here. And there is, look at 77 years old, and she had this thick choroid. Think twice. This is, yes, we can say age-related macular degeneration, but probably this is related to the thick choroid, what we call pachychoroid pigment epitheliopathy, which turn into neovasculopathy. I looked at this and I said, what's the cause of fluid? It's a CNV. So do I need to do OCTA for these cases? In the initial presentation and in the follow-up, would you do, and I need yes or no, would you do OCTA, Dr. Garabli? We don't have ICG in Egypt. We don't do fluorescein for 77 years old to die in your clinic. Anyhow, would you do? You do at baseline fluorescein and OCT and ICG. Dr. Salam in USA, you do everything?
I think in this case I probably would do OCTA.
انتوا عندكم ميكروفون ولا ما فيش ميكروفون؟
OCT only
Can we get a microphone because
But here, if this is CSR, which can happen in old age, it will show you the leaking point. And I had a case just for 2 weeks ago, exactly like this.
I was asking one question, you're answering completely different thing. So you do OCTA, you do fluorescein, you do ICG, you do OCT. What else? Can you do anything else? ERG. Dr. Nihal, would you do ERG? No. Okay, of course. So in USA, Dr. Ahmed Salem, what do you do at baseline?
I think 1 year ago I would do OCTA, fluorescein and ICG.
Yes.
And OCTA as well. Now I probably, in this case, in this age, I would just do OCTA and inject the patient.
Okay.
Yeah.
Doctor, anything to add?
I would do both baseline OCT and OCT angio. Now I do them because each one adds something.
Okay. Raul?
OCTA to confirm a presence of a CNVM.
Yes.
If not, then probably consider FA.
That's okay. That's what I agree. But if the patient doesn't agree, I would never do. Would you do fluorescein at baseline, Dr. Zaidi, for every patient?
OCTA.
OCTA. Of course. I would show you the OCTA now because the OCTA is the problem here. This is the problem. This is the OCTA. It's an active CNV. We don't need any further investigation, but if you can do, you can do.
Yeah,
but I never expose a patient like this. This is a typical CNV, okay? This is not the issue. The issue is you will inject this patient and you follow up the patient, and this is what happened. I'm sorry. 3 anti-VEGF, best corrected visual acuity 612, and there is still flow on the OCTA. I will tell you what I did. Sometimes when I see this, I say, maybe the 4th injection will kill everything. So I will never stop at it. I did the 4th injection because I don't want to waste time. This is 4th anti-VEGF. Same visual acuity, same picture, minimal fluid, and the vision is stable. No metamorphopsia.
I think the endpoint should be subretinal fluid rather than the OCTA.
Yes.
Because that's what you want. That's the one which is damaging.
Yes.
Even if the patient has a neovascular net underneath, but there's no fluid, I don't think so. We are really worried.
You will stop injection.
I would probably do a treat and extend for him.
But
based on subretinal fluid.
That's a good point, but the patient refused treat and extend. I mean, sometimes in Egypt, it's burden on the patient to treat every now and then. But if it's dry, would you count on the flow on the OCTA to continue injection, or you count on the OCT itself?
Actually, currently there's no consensus of treating based on OCTA. We
Yes.
require further studies.
This is the point.
We have to individualize.
But
If the
I mean,
patient
when
is-
I met this patient, it's my patient. So I said, would I count on OCT only, or I should respect the flow on the OCTA? This is what happened to me, brainstorming with myself. What should I do?
How many times you do OCTA and you'll find membranes and there is no fluid?
Yeah.
A lot, am I right? Which means not every single membrane on OCTA means activity.
Right.
Okay, and in this case will depend on the fluid, as Prasan said.
So
just to
we
treat
all
the
agree
OCTA.
that we have to depend on the fluid. Any objection? I mean,
And symptoms.
anyone will object this and count on OCTA? Your count on OCTA?
No, my objection is this is I can consider it a dead tree. There is no sign of it.
By the way, it's I cannot say that tree because this is a kind of PCV. I mean, it's like a branching vascular network. It's a pachychoroid. It's not the typical dead tree, but anyhow, there is a flow. I cannot deny there is a minimal flow, but I cannot deny this. Yes, Dr. Ahmed.
I think there's no argument. I think this works and this works as in Egypt. الفنانة يسرا بتقول كده ينفع وكده ينفع.
Thank you, Dr. Ahmed, for
This
this
works and-
comment. This has happened sometimes in Egypt. Sometimes we say we stick to this and we will follow up. I'm saying this because this is a retina specialist from all over all over the world. US, United Arab Emirates, Morocco, India, Egypt. I mean, it's different culture. But again, the only certified thing to inject is the OCT, the structural OCT. 2 months later, the patient came with the fluid, and look at the flow. It is not that much increasing, but there is a little bit increase in the flow. So we will agree that we will inject depending on the fluid, whatever, treat and extend or PRN. I did inject. And I did again look at the OCT angio. There is no fluid, there is flow. My message here is always count on the evidence-based. OCT angio sometimes could be diagnostic, but could be deceiving in the follow-up. This is my point. Don't look at the OCT angio, then look at without looking at the OCT and say, this is an active. It could be fluid, treat, there is no fluid, don't treat.
What happens if the patient comes with no fluid and you see an increase in the CNVM?
Increasing in OCTA, you mean?
OCTA, increase in the CNV amount.
It could be, this is, I mean, you're asking me, right? You're asking me. I will tell the audience. It could be, it happens to me. It could be an early stage where the flow is increasing, but the fluid is not reflected yet.
So we don't treat, but you ask the patient to come earlier.
To come, yes.
Because you're worried that the fluid will.
That's it.
CNV will leak.
And in the silent CNV, this is not a silent one, but in the silent CNV, the only trigger here, if you increase in the size and the flow, this is a precursor of fluid formation. But the pump here is still working. That's why it's pumping the fluid out. But once the CNV grows, the pump fails, you will find the fluid. And this is 6 months follow-up. No injection, still stable, and still. دكتورة نهال ده active ولا لا؟ ما انت بتقولي لي this is not a dead tree. I cannot consider this a dead tree. But this is probably a precursor because the flow is increasing. The fluid is not there.
But this branching in the human, it was not in the other, this branching upward.
But still is inactive, by the way. So OCTA is misleading. And again, to tell you the story, 2 months later, this is the story. OCTA could be a precursor. So watch, careful watching of this patient. Don't tell him come after 3 months. 1 month is quite good enough. 3 weeks sometimes is quite good enough because this is the precursor of the fluid formation. So again, that's what I said. And I did inject 3 injections, the macula dry, 6, 12, and still sometimes you have this flow. So again, I will not repeat this. OCTA is not a standard of care in this patient. OCTA is the only thing to predict sometimes that the flow and the fluid is coming, and this is a very good point to see OCTA but not to judge or to treat depending on OCTA. Any disagreement? Because this is a message for the audience. Always look at the OCTA, but don't consider treatment unless you find fluid on the structure OCT, and not only fluid. This is another message. Vision. If the vision, we are not treating OCT machines, we are treating patient. If the vision is stable and the patient is not complaining and the OCT is dry, continue, watch this patient. Don't hurry for injections because that's why I use PRN in this case, because treat and extend, you will never know when the fluid will come back. But here in the PRN, you get the message, and I have the ability to do OCTA every now and then, even without charge, to know what is going on for this patient. Count on the OCT, on the patient's complaint, never count on the OCTA. It's a guide for you that the fluid is coming, but it is not the standard of care in these patients. Treat and extend? It's a, by the way, it's sometimes, I will tell you the story, it's a very poor patient. And it's paid from her own pocket. So I cannot use treat and extend for her, and even all these OCT angios for free. I did it for myself. I did OCT and I follow up. But this is why I presented this. Sometimes the patient cannot afford treat and extend, but treat and extend would save you from this, but it will not give you the message. So if you are PRN, you will have the message. But treat and extend will kill this, will finish all this. Because you will treat, you will not expect the fluid to come back. But again, my message is don't look at the OCT angiography alone. It is not the standard of care. Up till now, it's good machine, it's good tool of investigation, but it is not, what can I say? We cannot depend on it. All the literature now, nobody used OCT angio in the standard of care in the follow-up. Even in the literature, they cannot, because the standardization, what's the meaning of flow, what's the meaning of increasing flow? There is no standard to say this is increasing, this is decreasing.
Dr.
For me, this is an ideal case of PRN follow-up, not treat and extend, because you have a lesion that is appearing on the NGO and you're not sure it becomes active and then non-active. So PRN, you will be able to detect early, and then you need to follow up PRN, whether you give injection or not. So treat and extend for me in this case is not ideal.
But it will never show you what's going on. I mean, treat and extend, she might keep dry for years because I'm treating while there is no fluid. I don't think the fluid will come back that rapidly because it took 2 to 3 months to get the fluid back. So if you're treating and extend to 12 weeks, you will never see the fluid. This is the point. But PRN is good to show us what's going on.
Dr. Magdy, there's a modified PRN, which I follow, which for self-paying patients. So what I do is after they are dry, a weekly or bi-weekly follow-up on OCT.
Yes.
To look at when the recurrence happens.
Yes.
And then rather than doing a treat and extend to find out the duration, you look at the PRN follow-up. Suppose the patient comes at 10 weeks and there's got a fluid. So I would probably inject and then call him every 8 weeks for an injection.
Yes.
Rather than doing an actual treat and extend.
I always, learn from the cases, but we need to get a message. PRN is not that bad. a lot of people still, I used to treat and extend in Egypt once the patient can afford, because of getting the patient in and out most of the time. It's very expensive, but again, PRN, it's a very good regimen, and sometimes in cases like this, because you don't know the fate of this. This is a 77 years with a thick choroid with pachychoroid. I mean, this is behaved sometimes differently.
Again,
PCV.
PRN could be the best as long as the patient can follow up regularly with
Yes,
you.
yes.
Otherwise, you are losing the patient in between.
Treat and extend is
Exactly.
But here, 612 after 3 or 4 years of follow-up, this is the best thing I could do for the patient.
If you're saying the patient is not affordable, why can't we try FFA and doing a focal laser if possible, if it is extrafoveal?
You can speak a little bit slowly so I can...
You are saying the patient is not affordable.
Yes.
Why can't we try doing a FA ICG and try to do a focal laser if possible, if it is extrafoveal?
Focal laser?
Yeah.
For what?
No, if it is extrafoveal, it's a PCV like this thing, right? If there is a leak.
But it's under the fovea. PDT, you mean? No, I mean, you are suggesting PDT.
Yeah, PDT or focal
We don't
laser.
have PDT in Egypt since 10 years up till now. And it's much more expensive than the injection, by the way. By the way, if she cannot afford, you are going to another choice. Another case with empty fovea. Yesterday I presented empty fovea and everybody was, making laugh of me. What's the meaning of empty fovea? Empty fovea. There is no fovea. Something like this, and you call it empty fovea. Yesterday is completely different, by the way. Some people were there. This is an empty fovea. This is a male patient, 20 years old and 28 years old. He had recent diminution of vision of both eyes after attending a party. Put this in your mind. And he had... He's studying in England, he's living in Egypt, he travels every now and then, attending some parties, have some fun, and then he comes back. He has nothing in the anterior segment, and this is the fundus. Subfoveal elevation, empty fovea, and he has no systemic illness.
Any IV use of drugs?
The same question yesterday, right?
IV.
I asked him, this time there is no drugs.
No drug.
You see, I expected this question from you, and I was going to remove this. But this time, there is no drugs. The clue sometimes...
Denies.
I will tell you the story. This patient was coming with his friend. Okay?
Yes.
Tfaddal.
Yeah, that's what.
Well, that's what you were showing.
Anything that pops.
Okay, this is the point. This is the clue. I think you have seen this before, right? Anyhow, he is coming with this patient, with his friend, almost the same age, and his friend was more worried than him. He came to me and said, please, doctor, is you going to be blind? I said, no. Please, doctor, if there's any treatment for this? I said, I don't know. Please, doctor, I said, can you calm down? The patient was not irritable. The guy, his friend, was very irritable. So I looked at him and I didn't like the questions. I didn't like the behavior. And I asked him, did you have any drugs? He said, no, I don't take drugs. We all know that the empty fovea is descriptive term. This is all the causes of empty fovea. Occult macular dystrophy, Stargardt disease, achromatopsia, solar retinopathy, drug-induced. So I went down to the drug because he has no history, the family is fine, he has no signs of Stargardt disease. I looked at the fundus, there is nothing in there. And it could be occult macular dystrophy, but it doesn't happen suddenly in both eyes in this age. So as I said, sometimes the clue is in the patient, is in who is coming with the patient, or is in the history. So I started with the history. What do you do in England? He said, I go to parties with my friends. What do you do in the parties? He said, we get a little bit high, no drugs. High by the popping these things. So, as I said, travel 4 times, and this is the clue. He's a gay. The guy is gay. So, this is what I felt from his friend, not from his. He never admitted that. And he gave me the clue. He's a gay, and once they go to England, it's very common over there what's what they called Popper's maculopathy. What is Popper's? This is the first time I see it in England when I was there, 2014. There's a drug where they pop it out, like small capsule, they pop it out so it makes a pop, and then they smell it. This smell gave them a very high level of happiness. This is what they call it, Popper maculopathy. It is a drug, and it is used to be vasodilator in the old days. But nowadays, it can be ordered on Amazon as a recreator. They spray it in the atmosphere, and it gives a very good smell. But here, they take overdose, and they smell a lot to get high. So this is what happened to him. Once he go to England, he attend parties with his friends, and they get this. So it's a slang name for a group of alkyl nitrate that are used for recreational things. They can spray it, they can smell it, they can pop it out, they can have overdose sometimes. And this is what causes the maculopathy. So again, ask him about the drug, he said, I never take drugs. I'm fine. And this is what happens. In gays, sometimes they don't use it only for smelling. It helps in relaxing the anal sphincter. This is another very bad issue. So they took it as a tablets or capsules to improve this during the... So this is the poppers, they smell it, they take it, it causes macular degeneration and what we called empty fovea, and they inhalate it and they order it online, and it's allowed in UK. صح يا دكتور أحمد? Because you were living in UK, it can be ordered. No, you didn't. You got me wrong. I never. He was living in UK for a long time, and I asked the people there. They said you can order it online. It's easy to order it online.
It actually, it became popular. Like I heard of it in like around 2011, 12 in the UK, and then we saw a few cases.
Yes.
And yeah, the other important differential is tamoxifen.
Yes.
And also Mactel.
Mactel.
But the Mactel, the retina would be thinner.
Yes.
Yeah, that's the other one.
I did also.
Yeah, but they get outer retinal because it's a neurodegenerative disease, so they get outer retinal as well defects as well.
So symptoms sometimes start immediately or within an hour after the drug abuse, and it's a bilateral visual loss with central scotoma. Subtly changes sometimes in the fundus you will never notice until you do OCT, and it's a striking foveal change, and this is the mechanism, because nobody knows exactly what it works, what happens in the fovea, but they imitate this like solar retinopathy. It is toxic to the retinal pigment epithelium, which can cause damage of the photoreceptor layer, and a degeneration of the photoreceptor or outer retinal layers will give you the empty fovea. This is just hypothesis. I mean, sometimes it's postulating this. So again, always ask about the drugs, even if there's no drug. Check the patient. Who is coming with the patient? If the patient is not worried and the other guy is worried, this is another issue, because sometimes it is very important to know what is going on. So this is my history can usually solve the mystery. Most of the time, if you take very good history, if not, you are an eye doctor. You have to be a good observer. Look at the patient, look who is with the patient, how he is speaking, how he is taking care of the patient. And sometimes the parents are very worried, but friends are very worried more than the patient himself. I don't believe that anymore. And failure to require about drug history and denial. And this is Egyptian, كأنك مش مظبوط يا, because we have a history, we have a like a player in couple of years ago in Egypt, and this is the expression for the gay people over there. So this is my message. The fourth case. Serous retinal detachment is not always idiopathic. We all know that there is a many causes for serous retinal detachment. So dig deep to find out most of the time, because don't look at the retina, look what is beneath the retina. And this is a female patient, 35 years old. She had left recent diminution of vision. Thank you, دكتور. مين اللي قال لك العمري ولا حد من الإدارة؟ ما أنا من الإدارة برضه. They are threatening me if I don't finish at 11 o'clock, they are going to, you know. Though I'm one of the executive committee, I mean, but they are threatening me. They send a message. They couldn't face me. They told the guy, and the guy come and told me. You see, nobody can face me. Even Amri, he gave, or Ashraf Almi, gave him the order, and then they ran away. And they left this, because this is a decent guy. I know him, and I respect him, so left it with a decent guy from Saudi Arabia to inform me. You have to finish at 11. That's sharp. So this could be the last case. Other guys there, you know, here it's execution is easy. So let's finish this quickly. I'm happy because everybody is threatening, but anyhow. Female patient, 35 years old. She had left recent diminution of vision, visual acuity 6.6 in the right eye, and in the left eye 6.12, no systemic illness. Could you find anything in OCT and fluorescein angiography in this case? Can you see anything abnormal? There is a druze-like thing in the temporal to the fovea, because everybody was looking inside the screen. Don't hesitate. Druze-like, but anything else?
Subvenous tortuosity.
venous thrombosity, but it is not the case. Here's the magnified picture, color fundus picture, and I changed the color to show you. Multiple drusen-like, right? But what else? Dark, not dark vessels, something under the retina. Pigmentation. And this is another change in the color to show you that sometimes playing with the color can play with your mind. And this is the OCT. This is the OCT. What's under the retina? It's a mass. What kind of mass can do this? We have a lot of differential, of course.
Hemangioma, choroidal.
Hemangioma.
Capillary.
Hemangioma. Could it be amylonotic melanoma? Could it be nevus? It's a mass. Pushing the retina. It's a huge mass.
Any history of pain?
I'm sorry?
History of pain. Pain.
No, there's no pain. There's no pain. Only a little bit of metamorphopsia and 612 vision. But fundus picture was not that conclusive, but the OCT was conclusive. Systemically well. But I know we need to exclude melanoma because this is the most serious thing. But as I said, sonar. So here is the sonar. Somebody from the corner asked, can you give us ultrasound? Of course I will give you ultrasound. I will not give you, this is a wide field imaging, by the way, and you can see the pigmentation under the macula, but this is a wide field image. I didn't like the colors, but this is what I scanned when she came in. And sonar didn't show. There is a mass and height and everything, but it is not shadowing what's underlying. The mass is not giving any shadow, So can melanoma do this? Why not? Yes.
So I think in my mind, the final answer is...
Can you get the microphone so everybody will hear you?
So in my mind, we had this situation several times.
Yes.
And in my mind, the final answer is between amylonotic melanoma and hemangioma is a combination of two things. ICG plus ultrasound. If you combine the two things, you'll be able to tell it's an amylonotic melanoma or a hemangioma.
How about nevus?
Yeah, nevus is a good one, but there's more fluid than you expect for a nevus, and more elevated for a nevus.
What is with nevus? What is against nevus?
I think it's more elevated and more fluid.
How about this?
Would
drusen comes with the nevus or comes with the melanoma?
Yeah, you're right.
So this is what my thinking. I did OCT angio even to see. Hemangioma, you would have never missed the hemangioma from the fluorescein angiography. You forgot that I showed you the fluorescein angiography. Hemangioma, no way to say hemangioma like this, right? So everybody was, sonar. You pushed everybody on the other side because you were asking for sonar. They forgot that I showed them fluorescein angiography.
Elevated for a nevus, right? It is more elevated than a nevus.
I know, but it happens. Drusen was the nevus. And I did everything, even PET scan, I excluded everything, there was nothing. The point is, would you treat with anything? Because we know all CSR, sometimes we give, like aldactone, like spironolactone, like these things. Would you try these things? Because it's like pushing on the choriocapillaris, increasing the fluid, pumping the fluid out of the retinal pigment epithelium. I don't know. But I will tell you what I did. This is 1 month later. What did I do? No way. I don't inject in these cases. No way. This is the trick here. That's why I said I didn't tell you what I do, but no way. This is, everybody's jumping for injection. I never inject in this case. This is no way to inject in this case.
Call back again after 1 month. Observation.
I did eralonar, which is ipilimumab. I tried. I said, why don't I try? It works in CSR. Sometimes it works. So that's what I did. And the patient went completely dry. And it's a proof it's not a malignant melanoma, it's not a hemangioma, it is nothing malignant, and there is no injection, by the way. I don't inject this. We shouldn't try injection in this patient because there is no rationale for injection in this patient. I'm sorry? I gave something like spironolactone. It's called ipilimumab. It was there. I can't remember, but it was there. It is written there. 2.9 and the elevation is it's a size, the height, and this is 2.9 millimeter.
The elevation is 2.9?
I think so. This is what's here in the...
So I think this is at least an indeterminate melanocytic or a melanocytic lesion, but I think it's, I don't know. Yeah.
But ultrasound was excluded, PET scan, there is nothing in there.
Worse as well.
And drusen was helping me to take the decision. And once I gave this, and I tried this after 6 months with another with another nevus. It works. I mean, sometimes it works, sometimes like CC. But again, we shouldn't hurry for injection. This is my message. You shouldn't hurry for injection in these cases. You should investigate until you find out there is no malignancy.
Yeah, and I think the more important is the thing is malignancy, and also the important thing is the follow-up.
Yes.
Because if it's malignancy,
yes.
it will progress slowly.
It will never stop. It will never regress.
Not only this, we always concentrate on one type of pathology, and this is just the response to oplineuron means CSR.
Yes.
Nothing more. What
yes.
I'm saying is high cortisone level, you are reducing the cortisone, that's fine. So just two concomitant pathologies maybe, and
it could be
the CSR, but
it could be
the nevus down there, and we shouldn't just be focused on one
because
area.
It's the same mechanism sometimes.
Yeah, the CSR can come, but melanoma will not induce CSR.
You see, after the macula is completely dry, almost dry, the drusen was clearly seen after that. Multiple drusen. You see the drusen overlying the nevus. It's one of the hallmarks sometimes. If you find multiple drusen, it will never be a malignant melanoma. It's 90%, 99%. It's a nevus. But it depends on because we have dark race a little bit, sometimes the nevus cannot be distinguished from the dark color of the fundus. In the lightly colored fundus, it's easy to get the melanoma or the nevus. So
how much oplineuron do you do in this case?
I give 25 milligram daily for 3 months, but after 3 months, she was completely flat.
Okay.
3 months. And this is, by the way, the OCT angio to exclude hemangioma, to exclude anything, because in the malignant melanoma also you can find vasculature over there. So OCT angio after flattening of the retina, I did that to prove there is nothing down there, there's nothing vascular down there. And as I said, serous detachment, it could be benign, it could be CSR, it could be nothing else, and you always dig deep to see what is going under, and don't hurry to diagnose malignant melanoma, don't hurry to inject, and always follow up the patient, exclude malignancy, and that's it. I think we still have 7 minutes, but I think they will come back now, and then we cannot front, and I respect this guy, Dr. Yahya. He's one of the most respected, so I will listen to him, because they have live surgery after this. So I will cut it short. I still have 3 cases. We can do it in Egypt someday, but thank you so much. Thank you for your listening. دي عشان خاطرك انت والله، مش عشان خاطر والله عشان خاطرك انت.
It is like, but I think
هتندهوا لنا الراجل اللي بيصور. دكتور زيدي مش هتطلع معانا الشباب بتاعه كده يا ريس. Can you take a picture for us? My mobile. You're a professor, of course. I don't know who's mobile this, but at least give him a chance. انا I catch myself والله انا ساعات بفكر اعمل ايه؟ اسوي what can I do? What should I do? What should I listen to the patient? ايوه ممكن. طب بس عمال جبت وكده.
Can you